All right, let's talk about something we see every single day at the pharmacy counter: chronic cough. You know, it can be one of the most frustrating things for a patient to deal with, and honestly, for us to help manage. It's way more than just a nuisance. It can really mess with someone's quality of life. So today, we're going to build a solid, practical playbook for navigating this, right from our side of the counter. Let's jump in.
So here's the game plan. First, we'll get a handle on just how big this problem is. Then, we'll walk through those crucial first steps and the red flags we absolutely have to watch for. After that, we'll identify the usual suspects and really dive deep into our main focus, the pharmacist's therapeutic playbook. And we'll wrap things up by looking at those tough, unexplained cases that can be real head-scratchers.
You know, when we talk about chronic cough, we are dealing with so much more than a simple tickle in the throat. This is a condition that can lead to some pretty serious complications. I'm talking everything from sleep loss and social anxiety all the way to things like stress incontinence and even rib fractures. It's a serious clinical problem that really deserves our full attention.
Okay, so just to make sure we're all on the same page, what exactly are we talking about here? The clinical definition we're using is a cough that sticks around for more than 8 weeks. Anything less than that is considered acute or subacute, and that usually has a different, often self-limiting cause. We're zeroing in on that persistent, nagging cough that just will not go away.
And you know what? It is incredibly common. We're talking up to 1 in 5 adults. Just let that sink in for a second. That means on any given day, a pretty significant number of the patients walking into your pharmacy are probably dealing with this, whether they bring it up or not. And this is really where we come in. As pharmacists, we're so often the first healthcare professional a patient talks to about a cough that's been lingering. That puts us in a perfect spot to start the investigation. So, what does a smart, systematic approach look like from our end? Well, the standard of care follows what's called the anatomic diagnostic protocol. It all kicks off with a really thorough history, and this right here is where we can make a huge impact. The single most important first question from a pharmacist's perspective is, are you taking a blood pressure medication, specifically one that ends in pril, an ACE inhibitor? I mean, that simple question can solve the whole mystery right then and there. The other steps, the physical exam, chest x-ray, spirometry, that's for the physician. But our initial medication review is an absolutely critical first pass. Now, before we go any further, it is vital to know when to hit the brakes on our investigation and refer immediately. These are the non-negotiables, the red flags. If a patient mentions coughing up blood, being really short of breath, unexplained weight loss, or fever, our job is simple. The only thing to do is advise them to see their doctor, and urgently. Our role here is to be the safety net, making sure these more serious causes aren't missed. So, once we've ruled out an ACE inhibitor and we're sure there are no red flags, our investigation turns to the usual suspects. And the good news is, in a non-smoker with a normal chest x-ray, the vast majority of chronic cough cases come down to just a handful of conditions. So, who are they? First up, we've got upper airway cough syndrome, or UACS. You'll know this better as postnasal drip. Then there's cough variant asthma, where the only symptom is a cough, no wheezing. Next is GERD, which can be super tricky because up to half of patients won't have that classic heartburn. And finally, non-asthmatic eosinophilic bronchitis, or NABE, which often pops up after an infection. The really crucial point for us: we dispense and counsel on the therapies for all 4 of these.
Okay, now for the core of our discussion, the part where we really get to work. Let's open up the pharmacist playbook. This is where we translate a likely diagnosis into real action through medication management and, most importantly, patient counseling.
For UACS, the evidence actually points to trying a first-generation antihistamine with a decongestant. And here's a great clinical pearl. The older antihistamines, like chlorpheniramine, are often more effective for this type of cough than the newer ones. Our key counseling here is to be very clear about the sedation and anticholinergic effects. And with pseudoephedrine, we absolutely have to caution about insomnia and palpitations, and always screen for contraindications like severe hypertension or heart disease.
Now, let's talk about GERD-related cough. This one is all about managing expectations. The most crucial counseling point you can give your patient is that a trial of a PPI or an H2 blocker can take 2 to 3 months to really have an effect on the cough. If they give up after a couple of weeks because they think it's not working, they'll never know. We also have to reinforce that lifestyle changes like weight loss and propping up the head of the bed are really the foundation of the treatment.
NABE is a bit more straightforward, thankfully. It usually responds really well to inhaled corticosteroids.
And for us, this is a golden opportunity to review proper inhaler technique and stress why sticking with it is so important, not just for it to work, but also to minimize side effects like thrush.
So you're probably wondering, where do all the over-the-counter cough suppressants fit into this? Honestly, their role is very, very limited, and it's our job to communicate the pretty significant risks. With codeine, we're talking constipation, sedation, and dependence. For dextromethorphan, the big one we have to look out for is the risk of serotonin syndrome when it's combined with SSRIs or MAOIs. That's a potentially fatal interaction we have to screen for. These are really last resort agents for a little short-term relief, not a primary treatment for a chronic cough. But what about those patients who feel like they've tried everything and they are still coughing? This is where we start getting into the territory of unexplained or refractory chronic cough.
So, unexplained chronic cough, or UCC, makes up about 5 to 10% of cases. And the latest thinking is that this isn't a problem in the lungs or throat anymore. It's more of a cough hypersensitivity syndrome. Basically, the nerves that trigger the cough reflex have become haywire and oversensitive. It's like the check engine light for their cough is just stuck on. And that's why the next line of therapy shifts to neuromodulators. We're trying to calm down the central nervous system itself. And that brings us to gabapentin, which is used off-label for UCC. When you dispense this, the counseling is absolutely critical. Patients have to start at a low dose, maybe 300 milligrams a day, and titrate up slowly to keep side effects like sedation and dizziness to a minimum. But the most important point on this slide is the need to reevaluate. This is not a forever drug. If there's no significant improvement after 6 months, the guidelines say it's time to stop the trial.
Okay, let's bring it all home. If you remember nothing else, remember these 4 things. 1. Always, always, always check for an ACE inhibitor first. It's the easiest win we can have. 2. Remember that up to a quarter of patients might have more than one cause, so don't give up if one therapy only helps a little. 3. Treat the cause, don't just mask the symptom with cough suppressants. And finally, number 4, counsel on patients, especially with those GRD therapies. It's a marathon, not a sprint. And we'll finish with a little look to the future. We are right on the verge of brand new targeted therapies like P2X3 receptor antagonists that directly tackle that cough hypersensitivity. As these new drugs become available, our role in managing these complex refractory cases, counseling on new mechanisms, and monitoring for totally new side effects is only going to get bigger and more essential. It's a really exciting time to be on the front lines of patient care. Thanks so much for joining me.